Hello everyone and welcome back. Today we are going to speak about thyroid acting agent or thyroid hormones that will cover the hormone used or agent used for hyperthyroidism and other agent used for the hypothyroidism. So this image here represents the axis supervision, the relationship between the hypothalamus, anterior pituitary and thyroid gland. This axis maybe present here the TRH released from the hypothalamus. TRH stimulate TSH and TSH will stimulate the thyroid gland and lead to the release of thyroxine and T3. T3 stands for triiodothyronine. So we need to be familiar with what the meaning of TRH and what the meaning of TSH, T4, T3. TRH mean thyrotropin releasing hormone. From RH at the end here, RH mean releasing hormone. This is linked to the hypothalamus. Then we have TSH. This is hormone released from anterior pituitary and anterior pituitary lobe from the pituitary gland. This will stimulate thyroid gland to release T4, T3. And in the blood test, normally we measure T4, T3, and TSH, and the normal level for TSH is between 0.4 to 4 milli international unit per milliliter. So this slide here presents the importance of the thyroid hormone and regulation of metabolism. And we have, as we mentioned there, we have two main hormones. We have triiodothyronine, T3, we have thyroxine, T4. We are going to discuss two cases and approach the appropriate treatment for two cases. As I mentioned in the earlier, we have hypothyroidism. Hypothyroidism, term name hypo mean deficiency, decrease. Hypothyroidism. Hypothyroidism associated with inadequate secretion of thyroid hormone, and the patient with the hypothyroidism suffer from bradycardia, poor resistance to the cold, and mental and physical slowing and mental retardation in children, and sometimes we see children suffer from dwarfism if this case not diagnosed early during childhood. On the other hand, we have hyperthyroidism. Hyperthyroidism, we have an axis in the thyroid hormone, and this lead to stimulate sympathetic system. We are here speaking about the catecholamines such as epinephrine, norepinephrine increase activated, and this will lead to tachycardia, cardiac arrhythmia, decreased body weight, nervousness, and tremor. Okay, thyroid hormone, you can see here in the thyroid hormone we have multiple follicles, and these multiple follicles consist of single layer of epithelial cells, and inside this follicles we have colloid, and this colloid rich with the thyroglobulin. Thyro belong to the thyroid gland. The globulin talking about protein, and they have abbreviation TG for thyroglobulin, and this maybe represent the storage of thyroid hormone. Regulation, as you can see here, for regulation we already covered that. TRH, for regulation, TRH stimulate TSH. The TSH will enhance uptake of iodide, I minus. Iodide will be uptake, enter the cell from the blood. So iodide available in the blood. The thyroid gland will uptake the iodide, then coupling the iodination of tyrosine. So iodide bind to the tyrosine, iodide convert to the iodine, maybe bind to the tyrosine with the iodine. Let me explain that for okay, tyrosine with the iodine. This will lead to the formation of MIT, monoiodothyronine. So monoiodothyronine then will condense with another monoiodothyronine, and this will lead to the maybe formation of diiodothyronine. Now, when the diiodothyronine bind again with the monoiodothyronine, this will lead to the formation of T3. The same will be applied when we have two diaminothyronine. This will lead to the formation of T4. So that's a thyroxine. So this is maybe the process how the hormones will be formed in the thyroid gland. Okay, this diagram here represents what we have. As you can see here, we have the blood vessels. Again, we have the blood vessels. Okay, we have the blood vessel in contact with the thyroid gland, and we have thyroid follicles, and we have thyroglobulin here. Okay, we have thyroglobulin, and inside this thyroglobulin we have the hormones. We have T3 and T4. So if you look on the left side, as you can see here from the plasma through the food or the GI system will provide with the iodide, and our food also will provide with amino acid. Now amino acid and iodide uptake by the thyroid cells, and iodide uptake, as you can see here. Then under the enzyme called peroxidase, iodide will be maybe two iodine will be condensed together to form iodine. So we have here iodine. Then amino acid will be uptake also, which is like important step for synthesis of thyroglobulin, and this will convert or formation of tyrosine. Tyrosine with the iodine, so binding tyrosine with the iodine, this will lead to the formation of monoiodotyrosine with a condense. This will lead to the formation of T3 and T4. Then T3, T4 will be released to the plasma in order to maybe practice their physiological function. Okay, the purpose of this slide here, two things. Number one, we have two main major point for us. You can see here we have T3 and T4, and this is, you can imagine this one like major cells. This is the thyroid cells. This is the entire thyroid gland cells. And in the middle here we have the nucleus, and you can see here we have cytoplasm. In the cytoplasm we have T4, T3, but the active hormone, thyroid hormone, will be T3. So therefore we have T4 will be converted to the T3, and the T3 will be able to enter the nucleus, and this T3 will practice its effect on the RNA and lead to the gene expression on the RNA. Okay, so this represents the action of hormones, or we can speak about mechanism of action on the molecular level. Number one, we have hormones in the blood, T3, T4, enter the cells. T4 will be converted to the T3. This is number one. Number two, T4 will be converted to the T3. T3 will enter the nucleus hormone. This is number three. Enter the nucleus hormone, and this will affect the RNA and DNA strand, and this is the nuclear strand, and lead to the final decision here, number four. Number five will be gene expression, and this will lead to the physiological response here. Okay, so this is the process for the T3, T4 in our body. Okay, so here we are going to briefly to cover two main abnormalities in the human body and two popular cases. You see it in the practice. Number one, we have hypothyroidism, mean deficiency. Hypothyroidism, we talk about deficiency, decreased level of thyroid hormones, and this is normally related to the autoimmune disease. And here we talk about Hashimoto disease, and this will lead to the destruction of the thyroid gland. How to treat this case? This case is treated with the replacement therapy, but because the situation will be permanent deficiency, the result will be lifelong replacement therapy, permanent replacement therapy. The patient will receive or will prescribe levothyroxine. Levothyroxine, we don't prefer to prescribe thyroxine. The reason for levothyroxine, this is a chemical substances, pharmaceutical drugs. Levothyroxine represent T4. Levothyroxine considered drug of choice for patients suffering from hypothyroidism. So the first drug of choice we prescribe it to the patients suffering from hypothyroidism will be levothyroxine. Advantages: once daily, long half-life. So we have two things here: long half-life. This will lead to the once daily tablet or like oral tablet. The medication start achieving steady state after 6 to 8 weeks, roughly 2 months here. So the reason we speak about this one here, when you see the patient in the clinic, come to the clinic, and you prescribe levothyroxine to your patient, like 25 microgram or 50 microgram or 100 microgram or like 150, depends on the patient case and severity of the hypothyroidism. You need to ask maybe you need to tell the patient come back to the clinic after 2 months to measure again, to do blood tests for TSH and T4. Okay, we have other preparation. Yes, other preparation will be liothyronine or liothyronine. We have Leotrix. Then we have natural origin thyroid, and this one dried thyroid gland. It's not popular in practice, but available in the literature. Liothyronine represent T3. Okay, speaking about Leotrix, and if you Google Leotrix, Leotrix is like combination between T3 plus T4. So the question here: which of the following medication used for hypothyroidism? And this medication contains consists of two hormones, T3 and T4. Okay, let me share this website with you to maybe present what is Lyotrix here. Lyotrix is a synthetically derived thyroid hormone replacement preparation. It consists of, so this is a key word here, the Lyotrix consists of levothyroxine, sodium T4, and liothyronine, sodium T3. So you can see it here for the information. It's very important. This medication, Leotrix consists of two hormones, T3 and T4 together. Again, this is some images for the Leotrix here. You can see maybe the package or the pharmaceutical form for the medication. Leotrix tablets consist of two main hormones. Okay, someone may maybe argue about how the levothyroxine T3 T4 work. T3 and T4 work here. It bind to the nuclear receptor. We already covered that. This medication used for hypothyroidism or patients of myxedemia coma. Levothyroxine is, as we discussed, is like it has a longer half-life. Levothyronine short half-life. Normally we start with low dose and escalate the dose, and we have to be careful using low dose with we prefer to use low dose in patients with heart disease, hepatic failure, or an elderly patient. We don't recommend to use it in the patient receiving warfarin, or patients suffer from diabetes, or patients suffer from the heart disease. Okay, on the other hand, now we cover the first situation, the first case, hypothyroidism. With the hypothyroidism, we prescribe the levothyroxine, liothyronine, or Leotrix, and we explain why we prefer like a synthetic thyroid more than the natural thyroid, because the longer half-life and less immunogenicity. If the patients are from hyperthyroidism, here, that means we have increased activity of thyroid gland, and you remember from the symptoms there, the patients suffer from tremor and from tachycardia, palpitation, how we can manage the situation. If we have goiter or tumor, they recommend to remove the part of the thyroid or all the thyroid. So removing part or all the thyroid gland. This removing could be implemented surgically or could be implemented by radioactive iodide 131. Okay, so we have two process to remove the thyroid gland partially or totally. We have surgical removal, or we're using radioactive iodine, I31, 131. This number one, this one option. Another option, using medication. We have two medication. These two medication inhibit thyroid hormone synthesis. We have propylthiouracil, or we have methimazole. So two medication used for patients from hyperthyroidism. I'll repeat it: propylthiouracil, methimazole. When you prescribe this medication will be concentrated in the thyroid gland and inhibit oxidative process for iodination. So this one we need to remember this process here. If you go back to the slide, here, if I clean this image here, and this is the site of action of propylthiouracil and methimazole. Propylthiouracil and methimazole. How this medication work? Inhibit. So you can see here, inhibit peroxidation, and this is number one. They said regarding the propylthiouracil work here. Propylthiouracil, they said propylthiouracil has an additional advantages. Propylthiouracil prevent conversion of T3 to T4. And let me correct this one. Prevent conversion of T3 to T4. Okay, moving back to the situation. So we have removing surgically or by radioactive iodide. Number two, we have inhibit hormone synthesis. Two medication, propylthiouracil and methimazole, by inhibit oxidative process that responsible for iodination. The propylthiouracil has another advantages by blocking conversion T3 to T4. This is a key word for us here. We need you to remember this one. This is another added value for propylthiouracil. Propylthiouracil inhibit conversion of T4 to T3. This medication need at least 1 month or 3 weeks to 1 month to see the effect of this medication. Another situation here. This medication carry the risk of a granulocytosis, which means decreased number of white blood cells, and here especially we talk about granules. So this is rare, but this one could be a life-threatening side effect, or could lead to the life-threatening infections. Okay, now we can. Someone may ask, okay, what is or what are the differences between propylthiouracil and methimazole? So you can see here both of them, propylthiouracil, methimazole, both of them inhibit synthesis of thyroid hormone. So this maybe similarity between propylthiouracil and methimazole. Both of them inhibit synthesis of thyroid hormone. This is similarity. But what is the difference here? You can see here propylthiouracil inhibit conversion of T3 to T4. So we have slide here to compare between propylthiouracil, methimazole. Methimazole, we prefer it as a first-line therapy, less liver damage. If you go to the propylthiouracil, second-line therapy, and may cause severe liver damage. Wow. So again, take maybe 1 month to 3 months to see the euthyroid, like a stable case of normal thyroid function. This methimazole, long half-life, this require single dose, compared with the propylthiouracil, short half-life, require multiple dose. Advantages, another maybe characteristic, they said propylthiouracil block conversion T4 to T3. We don't have this advantage here. It's not available in the methimazole. So we have all the similar color here. You can see here also methimazole does not block the conversion. So this one with a circle, this is maybe some differences. Both of them involve in the granulocytosis. Okay, that's good. Differences: methimazole considered like teratogenic, methimazole teratogenic. Okay, proper we can prescribe it during pregnancy, especially during the first trimester. It's safe during pregnancy. So now we can maybe bring the what we have between both of them. Methimazole, first line treatment, less liver damage, single dose, does not convert T3, T4 to T3, and teratogenic. We don't use it in pregnancy. Moving to the proper cell, second line treatment may cause severe liver damage. It requires similar dose. Another characteristic by inhibit or block conversion T4 to T3, safe during pregnancy, but it has the same. Both of them has a risk of a granulocytosis. Okay, here we have another emergency case in hyperthyroidism. So the situation here will be the situation will be here part of hyperthyroidism. Hyperthyroidism, which means increased activity of thyroid gland. The patient suffers from severe hyperthermia, severe tachycardia, agitation, tremor, unconsciousness, coma, and exophthalmos. Here, heart failure. You can see here we are speaking about emergency cases here, like emergency case coming from severe hyperthyroidism. A treatment, we can treat the patient with a methimazole to inhibit formation of thyroid hormone, beta blockers, especially propranolol, because you can see here we have tachycardia, we have heart failure, we have agitation, restlessness. All these propranolol present some relief. Corticosteroid and IV fluid. Corticosteroid, because corticosteroid inhibit the immune response, and if you remember, hyperthyroidism related to the autoimmune disease, and especially we talk about Graves' disease. So again, for thyroid storm, we have methimazole, beta blocker, especially propranolol, sedation and cooling, corticosteroid, IV fluid for the treatment. Okay, so at the end of this brief lecture, we already covered the medication related to the patients suffer from hypothyroidism. We discussed the levothyroxine, liothyronine, Leotrix, and natural thyroid gland. Then we move to the hyperthyroidism. We have two main medication, propylthiouracil and methimazole, and we compare between these medication, which one safe during pregnancy, which one is teratogenic, which medication associated with granulocytosis, which medication use like first line therapy, another medication second line, which medication may cause severe liver damage, and so on. So at the end of this lecture, thank you so much for your listening and watching this YouTube channel, and have a great day, everyone.